أعوذ بالله السميع العليم من الشيطان الرجيم بسم الله الرحمن الرحيم खुदा ताला आली कदर मुफद्दल मौलानी उमर शरीफ ने तारोज़ क़यामत दराज करे आमीन. Welcome and thank you for attending the SBMAA's 5th webinar. Today's topic is updates on breast cancer and breast health. Before introducing our speaker, just a few announcements. You will be muted by default throughout this webinar. If you are using a mobile device, we recommend that you change your orientation to landscape mode for better viewing experience. Throughout the webinar, you can type in your question in the Ask a Question box on your screen. After typing your question, hit Send. We will respond to these questions near the end during the live Q&A session. If you are experiencing any technical difficulty, please WhatsApp message at 818-267-6655. Lastly, any information provided in this webinar is not intended or implied to be a substitute for professional medical advice, diagnosis, or treatment. All content, including text, graphics, images, and information, is for general information purposes only. Safi Burhani Medical Association America, SBMAA, nor any of the speakers makes no representation and assumes no responsibility for the accuracy of the information contained in or available through this webinar. And as such, information is subject to change without notice. You are encouraged to confirm any information obtained from or through this webinar with other sources and review all information regarding any medical condition or treatment with your physician. Never disregard professional medical advice or delay seeking medical treatment because of something you have read or accessed or been presented through this webinar. SBMAA, nor any of the speaker is not responsible nor liable for any advice, course of treatment, diagnosis, or any other information, services, or products that you may obtain through this webinar. Now, regarding today's webinar, our speaker today is Dr. Mullah Aamir Bhai Gomberawalla. Dr. Aamir Bhai Gomberawalla is a breast surgical oncologist at Advocate Christ Medical Center and a clinical assistant professor of surgery at the University of Illinois in Chicago. He also serves as a medical director of informatics for the Advocate Aurora Healthcare System. Dr. Gomberawalla has focused his career on breast cancer and breast health and improving various techniques in the delivery of cancer treatment. He also has unique insight into how breast cancer specifically affects the Dawoodi Bohra community through work within the Amatullah Eye Cancer Prevention Program. His clinical and research interest includes high-risk breast cancer care, techniques in lymphedema prevention, and improving patient outcomes in cancer care. So without any further delays, we welcome Dr. Aamir Bhai Gomberawalla. Dr. Aamir Bhai.
Shukran, and shukran to the SBMAA for giving me the opportunity to present this information. Similarly, Bismillah shuru kariye, Bismillah ar-Rahman ar-Rahim. And the apnu main focus is and why we're doing all we do is we understand ke waida marastafo yashfin ke sagla shiva, and keeping that in mind, we try our best to help those around us. And so the purpose of this talk, what I wanted to do is kind of talk about various topics. Breast health in general and breast cancer is a very wide range affecting so many different specialties. So I figured the best thing to do is go over a few different topics in each of these different realms. And hopefully there'll be something for every specialty that's being presented. So if you're internal medicine and family practice and primary care, there'll be some things for you, a little bit on radiology, a little bit about medical oncology, surgical oncology. and other such subspecialties we'll try to touch so that there'd be something for everyone. And most importantly, I'm going to keep it relatively short because I want to hear what questions are out there so we can either dispel any myths or help other practitioners make sure that they're delivering the best possible care to their patients. So we'll start with screening, which is essentially the big crux of what we try to do in breast cancer care, is try to catch things as early as possible. So it continues to be a very large area that continues to change. Change happened in around 2015 and 2016. Mammograms still continue to be the mainstay, but there's a lot of controversies, a lot of discussions surrounding it. Is it 40? Is it 50? Is it every year? Is it every other year? Who should get it? This is, I'm not going to go through this in detail, but just to show you that this is the American Cancer Society's recommendations. They differ a little bit from the United States Preventive Task Force. Came out with a position statement in 2016. They're actually reviewing re-reviewing this data to come out with new recommendations, which will be out either next year or late next year or early 2023. But basically, there's a lot yet to be desired, and I think any of the primary cares that I have interacted with still aren't 100% sure what to recommend to their patients. You can generally feel safe utilizing any of these statements, but the biggest issues are that not everyone falls into these very clear-cut guidelines. And the biggest thing I want to point out is there was talk about no longer, in the 2009 statement, it was women should not be checking themselves and just let a physician check, and then that got a lot of negative feedback. So in this most recent update, they removed that portion. And what I like to promote is that each individual and all of my patients understand what their normal feels like, because many of my patients, despite getting screening, do also find their own little masses and different nuances. So it's something to keep in mind. I want to make sure that everybody is clear. There's been a lot of focus on something called dense breasts, and want to make sure everyone understands why it's important. So in 2018, at least in Illinois and then other states followed subsequently, that a woman's breast density, which is a mammographic finding, not a physical exam finding, just something that they find on mammogram, should be told to them in their mammogram report. And why is that a big deal? So this kind of takes the 4 different categories. One of the ways to categorize it is in these 4 different subsets: fatty, fibroglandular, dense, and very dense. And why is this a big deal? The reason this is a big deal is that these last dense, extremely dense, there's a lot of white in this picture. And cancer, as well as calcifications, both often show up as white. And so it's important. So trying to differentiate white on white is rather difficult. So oftentimes mammograms can hide this. And so if you're dense, you should get supplemental screening, and we'll get into that. Some other controversies that I've heard, especially in conversation with different primary cares, is that they've heard various myths like, oh, mammograms don't do anything. They just catch a cancer. They don't prevent anything, which is true. They don't prevent cancer, but they do catch it as a very easily treatable stage, and we'll come to that in a little bit. Also, any of the population studies that have been done, the ones that are done with large US registries are often fraught with mistakes. These large databases aren't very inaccurate, and there's lots of loss of follow-up. Population studies also don't matter when the person in front of you has cancer and they're asking, well, I didn't get a screening test 2-3 years ago because my doctor said to wait 2 years. And now they're coming in with a little bit of a later stage cancer. So when it's you who's sitting in front of the patient and they're asking why, it's a little different than when you quote percentages. The question about overtreatment that I hear a lot is that, oh, well, when I read these papers, they're saying, oh, these X number of cancers would not have led to cancer death. And all of us know that at this moment in our current understanding of these diseases, we don't know which ones will actually harm the patient and which ones won't. We like to think we do, but in reality, there's no way to predict which ones will actually end up hurting the patient long term. So it's important to treat each one very seriously. The biggest concept that's been started around 2020 and is going to continue in each health system is pushing towards this personalized screening. So we know that mammogram for everybody at a standard statement for the entire U.S. is not really going to be very, very good. So now we try to push for more personalized screening. So what I'll hopefully do is kind of present what kind of a little algorithm that you can use. Similarly, getting back onto that statement of, well, if we do screening, we're going to find tumors that we won't hurt anybody. The best studies that are out there come from Europe because their data is very robust. They're usually a uniform population, and they have centralized healthcare, so their data capture is very robust. And so what all of them have shown is a very significant reduction in mortality. And anywhere from 2 to 3 women will be prevented from dying of breast cancer for every one that could be quote unquote overtreated or overdiagnosed. And we're just simply not there where we can tell which cancers will harm our patients. And just some other numbers that can help you understand the importance of screening is in the US, where screening is robust, 1 in 7 women will die of breast cancer, of those who have been diagnosed with breast cancer. And these odds are very different in these other populations that don't have robust screening. So 1 in 4 in China, and this next statistic probably hits home for a lot of us, is that 1 in 2 people in India who gets diagnosed with breast cancer dies of their breast cancer. So when hopefully I've portrayed that we shouldn't really be worried about overtreating at this moment just yet. And to put other numbers in perspective, for every 40 people that abstain from smoking, only 1's actually being saved from lung cancer. So there was a large push. So hopefully we won't lose this momentum within this crowd. So I tried to make it simple. You get your annual mammogram starting at age 40, or if you're at least start the discussion with your patient to see if that's something that they're interested in. Stop when life expectancy is less than 10 years. So, some people will say it was at 75, is at 80. We can just have that conversation with your patient. It's very difficult. This I find to be amongst the most difficult challenges because you really don't have a great idea as to where patients, when that is. But traditionally around 75, 80 would be a reasonable time that you should at least start this discussion of maybe you can stop screening. And if they have something in their report about the words heterogeneously dense or extremely dense, just add a screening ultrasound. I wouldn't recommend adding 3D mammo or breast, which is also known as breast tomosynthesis. The reason being that just adding additional mammographic images, which are already problematic because they don't show what's within dense breast very well, adding that doesn't help. Now you can do ultrasound on top of 3D mammo, which is a very effective way as well. And then if they're high risk, add MRI screening. So this is what majority of the cancer institutions across the US are doing. And the most important thing that we'll focus on now is actually who is in this high risk category. So you define high risk by a number of factors, and the most important one being their family history. So all of us, especially within our community, need to know, we are a very close-knit community. It's important for us to realize who within our family has what cancers. So make sure we're imparting this to our patients. Atypical cells on biopsy will automatically put any patient in the high-risk categories. So anytime someone has had a biopsy report of atypical anything, flat epithelial atypia, atypical ductal hyperplasia, or any such things with the word atypia, that'll automatically bump them up into a high lifetime risk to allow the insurance companies will pay for their MRIs. So what tools do we have to calculate people's risk? The most common one is the one that's bolded, is the Tyrer-Cuzick model. You can use it in young women. It's the most accurate for taking family history. Of note, no model is able to calculate risk for atypia. They all overestimate it. So for example, if you have atypical cells and you're 40, it'll calculate your risk as high as 40 to 50%, but actually it's closer to 20 to 30%. But it'll always be in the above 20% range. So I would suggest not to use these models. Just if they have a biopsy of atypia, you can just write that their lifetime risk is greater than 20%. And you should send them, probably send them for to a breast specialist in this sense, if they've come up with this high risk. Other things are genetic mutations, which I'll get to in a little bit. But what you should do for these high-risk patients is send them to some type of specialized breast program, consider hormone MRI screening, and then also consider chemo prevention, which is underutilized, I would say, but it's understandable. It's both underutilized in my Caucasian patients as well as my South Asian patient population and minority patient population. It's just hard to get people to take anything for prevention. We can see that not only with breast cancer, but any other long-term illness, and now we also see it with the virus as well, that taking something for prevention is still a challenge that we all face. I want to spend a little bit of time talking about genetic testing because this is something that I think is not as well known. So the guidelines for which insurance companies will pay for genetic testing, they're very lenient. You just need to have a few risk factors, a few family members with various cancers, 1 or 2 with breast cancer, anybody, single person with ovarian cancer in a first-degree relative, pancreatic cancer in a first-degree relative, you automatically qualify for insurance to cover your genetic testing. And why is this important for us specifically is that as of this moment, none of ours, very few percentage of our DNA is in this larger population that's being studied. And so often our genetic mutations that may occur may or may not be captured by the genetic testing that's there. But as we add to this database, that's going to be important for us. And also in the future, it may be important for us to identify within our group certain mutations. Similarly to the Ashkenazi Jewish population, they have their own, why everybody in this room who's a medical professional has heard of this group is they have their own panel of genetic testing. They're very ahead in terms of that. And I think that we can not only catch up, but eventually surpass. The NIH also provides free testing. So please get my contact information after this, and we can help guide on how to get genetic testing in a very robust and easy manner. And then eventually we'll be making a confidential forum will be made available to our community to just discuss these different topics. So please keep that in mind and feel free to reach out at any time. Some newer techniques that may have been out there that maybe some of the group has heard about in terms of screening for mammograms that have come out in the last 4 or 5 years, I want to just touch base upon. So some of my patients and some of my primary care providers ask about this thing called thermography. I think 2 or 3 years ago, there was a news article from Britain talking about how somebody on a thermogram scan in one of the theme parks somehow found breast cancer, and that got a lot of good press. But in actuality, it's a very poor study and not sensitive enough. So it's not a substitute. I wouldn't really, put a lot of weight in thermography. These next two, though, I would. So if you're a radiologist or part of your hospital administration, I do think automated breast ultrasound used for ultrasound screening it's a powerful tool, helps find small masses that would be missed otherwise in dense breast. And if you are at an institution that sees a lot of cancer, doing accelerated MRI, so instead of having a 45-minute test, there's going to be a large push to get these tests shorter, especially for our screening patients. So this last one, accelerated MRI, is what our current institution is pushing. There's a lot of good data out of Mayo Clinic about this. So why are we spending so much time talking about screening, catching things early? I hope that's relatively clear, and this slide isn't brand new epiphany for anybody, but the survival differences is quite stark. And as we go through the rest of our talk, I just want to make sure that we understand how easy it is to catch these cancers in stage 0 and stage 1, where our survival rates are very high. And as you go down, and a large portion of our population that we treat, sadly, we find in stage 3 and stage 4, and it becomes very difficult to treat these patients. And not only do they have to go through more treatment and more difficult treatment, they have to go through treatments that are, not as that don't have the same outcome. So let's kind of continue to focus on catching things early. I want to spend a little bit of time talking about some updates within breast cancer treatment for any of the practicing clinicians who might fall into this category. The first one is not super new, but just to let people know that we don't butcher our patients the same way that may have been done many years ago. Breast conserving surgery is still the mainstay because we're able to catch things relatively early, and we can do things in such a way that you can't tell. So I actually had to draw in these patients' scars. She had treatment on both sides. And given new guidelines, we don't have to remove large amounts of the tissue. We can just take the cancer out, leave the rest of the healthy breast there. And there's actually no difference in survival. So I'll hear a lot of my colleagues within that I talk to within the South Asian community that say, "Oh, just get a mastectomy. It's much easier or better." I don't necessarily think that's true. There's very effective means. And most importantly, that there's no difference in survival. And there's even some studies coming out showing that there's slightly improved survival, but I just say no differences because those studies aren't really strong enough to take away the previous data that's already there. Other techniques is that this used to be how breast patients used to look after mastectomies, and now you can do what's called mastectomies. This is probably the last 10 years, gaining a lot of popularity, that you can, again, I drew in this scar. She has had surgery on the left side, and you can hardly tell the difference. So just keep that in mind as we're counseling our patients. For radiation, another important topic is that we don't need to use as much. So while there is intraoperative radiation, which isn't super new, the next topic is does everybody need radiation? So even in our guidelines within the NCCN, they're starting to say that it's reasonable to omit radiation in certain patients above 70. So if you're a medical oncologist, have that conversation with your patients and your radiation colleagues to say, hey, does this patient actually need radiation? Will it really help them? One of the topics that I'm particularly passionate about is something called lymphedema. So many of the people in this call hopefully have heard of it. Many, I'm sure, have patients who suffer from it. And it's probably the number one cancer-related topic and complication, aside from your recurrence, because that's more not iatrogenic. This is actually iatrogenic. That's something that patients very fear, and is actually a significant reduction in their quality of life. So lymphedema reduction, I sit on a national panel that talks about breast practice, and the first thing that we teach is if you don't need to operate on the axilla, don't. So for DCIS, for early stage tumors, we don't always need to check the lymph node status. As of 2020, December 2020, there was a landmark trial that came out saying that even if your lymph nodes are positive and you have an estrogen-sensitive breast cancer, if you have up to 3 lymph nodes positive, you don't need chemotherapy. So it's not changing your medical therapy. We already talked about 70-year-olds not needing radiation. So if it's not changing anyone's treatment, don't even go into the axilla if you don't need to. So for those medical oncologists here in the group or primary cares, just ask the surgeon, hey, do you need to check the axilla? But if you do need to check the axilla, one of the techniques that I try to teach other surgeons is something called reverse mapping. It's a simple concept. Instead of just focusing on the lymph nodes that drain the breast, put a different color dye in the lymph nodes that drain the arm, and now you can see them and easily avoid them. You may think that it sounds simple. It absolutely is simple. It's just not taught enough. And then it can get complicated because what happens if you need to take these lymph nodes? Well, some surgeons do have the ability to reconnect those lymphatics to other portions of the body as a preventative method. This is a lymphatic venous bypass that's shown here. Plastic surgeons have been doing this to treat lymphedema for a long time. But if we can do it preemptively, why not? It's a much easier surgery, and even lowly breast surgeons can accomplish this. Probably the biggest update in the last 5 years that's currently gaining momentum, and I imagine will be standard of care within the next 3 to 5 years, is lymphedema screening. So the old method of how we used to check for lymphedema is we used to, do our surgery and treatment and radiation on patients and just wait. And those who got it, we would try to treat them. And that's more, in this timeline of, they're already having large amount of swelling, difficult to treat, and you're basically sentencing them to lifelong physical therapy sessions and kind of lifelong worry about their arm. But there's a new method utilizing something called bioimpedance spectroscopy. And the most common method of this is something called LDEX, and the machine is called SOZO. And basically what this does is it uses fluid analysis to evaluate the fluid status of each arm and or leg, depending on what you're looking at, and can catch any sort of changes before the patient notices it. So that you can do a treatment, physical therapy, occupational therapy, and a sleeve for about a month to 2 months. And this will kind of halt and reverse any sort of lymphatic drainage. So what the studies show is that neovascularization does happen in this early stage if you find it enough and actually start focusing on treatment to allow for new lymphatics or recreation of flow back into the systemic circulation. So if you're a hospital administrator or in a large cancer practice, this is an excellent tool. I encourage people to get it. It actually reimburses very well. And can be a positive impact for your patients as well as your practice. Some future uses that you'll see it in, I imagine you can check fluid status, muscle mass, bone density, so your DEXA scans. And it's a very simple product to use. You just stand on it like a scale. It's very similar to those scales that you've seen in health fitness stores where that tell you your body fat index and stuff. So it's very simple. And for our medical oncology colleagues, as well as those who may be in this realm, I want to just touch on some newer therapies that are out there one is currently in practice, these Pdl One Inhibitors. And so one question that many people ask, both layman as well as physician, is what makes cancer so hard to detect, especially by our immune system? And one of those things is this thing called PD-1. And while, to not bore people with immunology, but it's actually a very interesting phenomena that happens, is that cancer cells put out this receptor called PD-1, and it's a checkpoint that each of our immune systems and T cells will go and interact with this cancer cell. And when this PD-1 is there, it's kind of like a handshake saying, hey, I'm of the host, don't worry, I'm okay, leave me alone. And these Pdl One inhibitors inhibit this interaction, and it allows our T cells to then attack this cancer cell. And what I love about this slide is that about 5 years ago, I had this slide in my future of breast cancer talk, and now it's recently, as of July of this year, it's now standard of care to give this in active, not stage metastatic stage, which is where a lot of these medications are often given, but now it's finally there for adjuvant and neoadjuvant, so most specifically neoadjuvant for triple negative breast cancer patients. So it's wonderful to see the progression that we're making. This next thing is about T cell transfer, so CAR T cell therapy. There are trials just in their early stages so hopefully this is something that may or may not come into fruition, but it's a great idea. Basically, you take T cells, kind of recharge them, make them kind of able to identify that own patient's cancer cells by using their biopsy tissue, and then reintroduce these into their bloodstream to help treat these cancers. So currently trials are going on for metastatic breast cancer, but early in its infancy. So we'll kind of switch gears now to talk about how has cancer in general, and specifically breast cancer, affected our population. And this came into light throughout, I've talked about, many people probably on this call have heard me discuss this, but it really hits home for me when I'm in my clinic every day. and I see generally white Caucasian patients who are coming to me with first stage disease, and I'm offering them easy treatments and great survival, like we presented. And I see a patient of South Asian descent and often other minorities who are coming to me with literally the same subtype of cancer, but unfortunately it's in the third or fourth stage, and we're talking difficult treatments with survival that I know is going to be relatively poor. And how can we so what are some ways we can, even the playing field again, get awareness more in our local discussion, and at least here in the United States, get everybody talking about it like we do on a society level. So through Maulana Raza and Dua Mubarak, this program, the Untitled Cancer Prevention Program, was launched in 1436, and we had 4 years of data that we analyzed. And the reason why these last 2 years aren't included is because COVID within our community has taken up a lot of people's time, I'm sure people can imagine. But we've had this data and we've analyzed it. So we presented this previously through the SBMAA and other avenues, but 16,000 women have participated, as well as of those 16,000, it shouldn't just say women, it's a few men as well as their male counterparts to help us, like People's Better Halves and other men in the family, to get us generalized cancer data. This is the breakdown of where they've come from. The next slide is the main crux of it. So what we found out is that by far and away, the prevalence of breast cancer in our community is very large. It almost reaches the US average. And the problem with that is that the majority of cancers that are caught within our community are stage 2 to 4, and the ones usually caught in the United States are stage 0. And these numbers and data are relatively staggering. So the women above 40 within our community who have had even one mammogram is 6%, and those who have had in the general US population is 75%. For those here who think like, oh, well, United States women, my Bori patients, they're getting screening, that number is actually 25%. Only 25% of our women in the US so far from this population. And imagine this is the population of people who are interested in breast cancer, who are filling this out. Only 25% are getting their mammograms. Only one mammogram. Not multiple, not yearly, but just one mammogram. But again, most important, remember, mammogram is an annual thing or biannual at the minimum, so it's not just a one-time thing. Cervical cancer, we don't have any because of our practice, and many of us, due to our lifestyle, will not be at significant risk for this. And so, but yet, people are still getting their pap smears. And so 8.4%, that's worldwide. In the US, 66% of women are within our community, the Dowdy Borough community, are getting their pap smears for a cancer that is extraordinarily unlikely to affect them. So we need to refocus where our concentration is for our patients and make sure they're getting the right things that affect us. And then the prevalence of uterine cancer and ovarian cancer, similar to the US population, and for uterine cancer a little bit less in general. Total cancer prevalence within our community for both men and women cancers, 1 in 4 people, which is a little bit lower because than the US population. We do have generally a healthier lifestyle with no smoking, no drinking. So that's probably a big reason. All of the other Shifa stuff that Shifa concepts, and obviously the concept of this talk of why hopefully that we are getting less and less cancer. But I would emphasize that not only if we continue to do the things that we're taught, but also utilize the benefits of Western medicine to help eventually then lead to the next step of prevention, which we didn't really get a chance to talk about too much, but maybe a different talk. We can talk about methods to prevent it through dietary actions and such. It's going to be important to kind of focus that we can actually get this number down even further. So the bigger picture of the scope of the program is to eventually, we're uniquely set up to find environmental causes of breast cancer. We can get true age risk for our patients. So for example, In China, the average age is 40 to 60, not 50 to 70 like it is in the United States. So they should be starting at 40, and it's not really controversy over there. We can expand our preventative concepts to other cancers and potentially identify genetic markers within our community. So I hope that I kept a majority of yours attention, but if I didn't, now's the time to kind of peek up and perk up and see, what questions you guys may have. I'd love to hear from the audience and, fire away and have them by. Go ahead and
All right.
Continue on.
Thank you so much, Aamir bhai. Excellent presentation. We have quite a few questions already, so I will take the first one. Are Moomina? So I guess this question was posed before. I guess you had provided your slide on the comparison between Moomina and US, and the question was: are Moomina more prone to breast cancer as opposed to general population? And if so, what is the reason? And if not, why not? So I think,
yeah, it's a great question. I would say that based off of my experience is that there are pockets of our population that likely may have a genetic predisposition to cancer that needs to be identified, and we can identify those. At least start with the US population where it's free, available. So if you have patients that you interact with, encourage them to do genetic testing. I do not think that we are at any a significantly less risk than our average US population. However, breastfeeding, and our community encourages, and our dean encourages you to breastfeed for 2 years, is a well-known reduction in risk for breast cancer. We don't generally smoke, we don't generally drink alcohol. However, we continue to see the actual prevalence of breast cancer, again, it's similar to the US population based off of the world. So this is majority India, only about 500 US women out of 16,000. So I can't say a US Moomina more likely, but if this program's goal is met within 10 years, I will have that exact answer. For US Moomina, who have now been here for 2 generations, are they at higher risk than Indian Moomina of getting breast cancer? And if so, then we know that the exact reason is probably the environment we're in, the food we're eating. Because even with phase, the benefit of FMB is like we're all eating masoor dal on Mondays. Now the food that we're eating is very similar. So now it's just where it's coming from is the main difference between all of us. So we can actually get environmental data, and we're very uniquely positioned to get this information. So I hope I kind of answered the question.
Thank you. Shukran, Aamir bhai. The next question is, can a Moomina go directly to Amatullah Eye Center for treatment?
So right now there is no Amatullah Eye Center. Right now it's just a preliminary screening program and prevention program. It's through ITS at the moment. You go through the Umar Sehat Burhani Medically Data portion. You click on ITS, or you sign into ITS, you click on Burhani Medically Data, you enter in your information. Now, we are hopeful in the next year to create local liaisons who, if anybody requires treatment or wants a second opinion, that'll be available. If there's any Moomina that has any question or would ever like a consultation for their breast cancer treatment, I'm more than happy to provide them with advice should they need it at any time. So hopefully my contact information can be shared, and it's obviously a privilege as well as a khidmat to be able to offer that. But right now they cannot go directly to the Amatullah Eye program for treatment at the moment.
Got it. Thank you. Shukran. And we will definitely share your contact information, Aamir bhai. Thank you so much for that. Third question, how would you advise your patients to inform their genetically related family members?
So I think that what they're asking is if they have a genetic mutation, how do they inform their patients or their family members, or if they feel like their family member is at risk for this. I usually just tell the patient, you can go to the NIH website. Again, after, please contact me. We can arrange for ways to get people to get tested. Fortunately, I'm in a position, and most people who work in large cancer institutes or large hospital systems will have a genetic team. So through the pandemic, one of the things that have come out that's positive is that now these genetic meetings are mostly remote, and you can set up an appointment, do a consultation, and get a kit sent to you by mail, spit in it, send it back. 23andMe, Color are various publicly available non-medical genetic analyses. So Color is the most medical of them. So if you were to get one, you can choose that one. But I would suggest to, in your local community, local hospital system, wherever that may be, they, I'm sure, have a genetic team that the patients and any of their family members would be able to just call, set up an appointment, and get it covered. Hopefully that answers your question.
Thank you, Aamir bhai. The next question is mammogram still needed after bilateral mastectomy to check for reoccurrence?
So no, if you have a bilateral mastectomy, there's no more breast tissue. So if the patient has had a bilateral mastectomy, they should see either some breast specialist, whether it be the surgeon or medical oncologist, once a year. If they have implants in, every 2 to 3 years, they should be getting an MRI without contrast to evaluate the integrity of the implant for silent ruptures. So they don't need a mammogram if they've had a bilateral mastectomy.
Got it. Okay. Thank you. Next question. Can you further elaborate on why breast 3D tomo imaging is not that much more helpful for patients with dense breasts?
Yeah, so I mean, I think don't get me wrong, tomosynthesis is better overall than just a mammogram, but I would not recommend it as a substitute for a woman with dense breasts to, I think ultrasound, looking at the breast tissue through a different technology. So let's say your tomosynthesis creates 30 images of this breast, and then I've pulled up my dense breast slide. So let's take this patient who has heterogeneous dense breast. That tomosynthesis is just going to show more of this dense breast tissue using the same technology. Yeah, it is better than only your 4 films. But look at that breast tissue through a whole different medium is going to give you a more robust picture to find things that are hidden often in dense breast tissue. So the best way to do this example is if you can find a mass on mammogram, and then you take an ultrasound to that ultrasound mass is going to be visible, not just probably to you, but to the patient, to any layman. It's a much better, I feel like, much better to offer them either automated breast ultrasound or screening breast ultrasound in general, that can be handheld too, to catch these masses than just 3D tomosynthesis. I would say in most cancer institutes, 3D tomo is kind of like the basic now. Everyone gets that even for their screening. Once that says dense breast, then they get sent for automated breast ultrasound or 3D or handheld screening ultrasound. And then for those high-risk patients, again, MRI is better. So I hope that helps answer that. More pictures of more poor pictures doesn't add that much, and a better medium using ultrasound, I think, is better.
Got it. Thank you, Aamir bhai. Next question. Can you please review office screening modalities?
Can you repeat the question?
Can you please review office screening modalities?
So in your office, so if you're seeing a patient, the basic screening for their breast health is to at least have that woman do a breast exam by a physician once a year, and then send them for some type of imaging study, and specifically mammogram plus or minus ultrasound plus or minus MRI if they are high risk. Other screenings that you can do in the office, I doubt that there are going to be widely available. So it's mostly you have to refer them to an imaging center to get screening. The only screening you could probably do in your office is a physical exam, which for some women may be enough. So for example, one of the talks that I give is If you're a low risk woman living in a country that doesn't have as high of a risk as the United States, for example, in India, for example, where mammogram is not widely available, maybe all you need is a physical exam once a year. But for the US population, there's no question, because of our high prevalence of breast cancer, a mammogram at the minimum should be done either, I think, annually, you can say biannually, either one, starting at age 40. But there's nothing you can do actually in the office aside from a physical exam.
All right. Thank you. Next question is, what strategies can we use to encourage Moomina outside the United States to get screened when appropriate?
I think talking about it, emphasizing that, the most common things that I hear are, I'm fine, so I feel fine. Or sorry, I feel fine, so therefore I am fine. Emphasizing that if cancer is caught late, there's not only is the survival rate low, the treatment that they have to go under is much more difficult. We often use saying, mola mana bachao se, and while that's all true, and that is actually the most truthful statement, there's no reason to not use the technologies that are on this. I've heard people utilize the phrase that even mola goes to the doctor, that can hopefully help. And since this program is done within our community, it's hopefully can help encourage it. But honestly, talking about cancer and breast cancer and being more open about it and not having it be something that we're ashamed of or worried about, or it will really help. The more we talk about it, the more it will become into fruition. Everybody, especially breast cancer, everybody has a mom, everybody has, so we all should be able to kind of rally behind this for our community, because it is by far and away the largest cancer that our community faces.
Okay, shukran. The next question is, on your questionnaire on the ITS website, is there a field for whether they have had genetic testing done? If so, what is the percentage?
There is not yet. We did not put that in because we didn't want to confuse people or make people think that we're able to offer them genetic testing, because at the time we were not. We're looking into now potentially adding that. So we don't have a percentage on women who have done even the basic genetic testing.
Okay. The next is, please repeat or clarify what age women should start annual mammograms. 40? Or is it just still not fully established in the guidelines?
So the American Cancer Society, it says 40. So every breast cancer, breast specialist, any cancer program across the United States is 40. To make it simple, let me pull up my slide here. And this is what we practice in our hospital system. This is what's advocated throughout our primary cares, and not just mine. I would say University of Chicago, Northwestern, the American Cancer Society, American College of Surgeons, every national cancer body, American Society of Breast Surgeons, everything is. This is the slide, like kind of a take-home slide. I hope everyone can see it, but basically 40 annually. And add ultrasound if they're dense, and if they're high risk, add MRI.
Got it, bhai. All right, next question is, I'm not sure.
Okay, before we go on to the next question, I just want to add, you don't need to do all, if you're high risk, you don't have to do all three. You don't have to do mammogram, ultrasound, and MRI. You can drop the ultrasound, because the MRI will catch the dense breast issues that mammogram is behind.
Got it. Okay. No problem. So the question is, so FMB can be helpful to gather data on breast cancer screening?
Yeah. So this concept is this. So what makes our community unique, and why do I feel that the Valley Bora community is uniquely set up to answer questions about cancer that no other community is? So if you look at us as a community, we are homogeneous, we intermarry. So genetically, over the last maybe 150 years, we're very similar genetically. Our lifestyles are very similar. And now, over the last, I think maybe 12 years since Thali has been given through each home, we're all eating very similar food. And as this continues, the fact that our menus are being set internationally and we're all eating similar foods for every meal, our lifestyles are the same. The only difference is where we live. Even Maulana says this in Bayan ke, Sagla Sarkache, America, India, everything's the same. And very much that's true. So now, if in 10 years we find that the US Moominin have a higher rate of X cancer compared to a Moominin in London or India, everything else about them is generally the same. So while you can't make it direct causal analysis, though, we're the only people who can use this population data to suggest and have a strong suggestion that environment plays a larger role than just genetics. That why would our third generation or second generation US Moominat or Moominin have a higher rate of cancer compared to similar people in India when our lifestyle is the same? Only difference is our environment. So that's why FMB, as amazing of a program as it is, it can actually impact one day maybe breast cancer screening. I hope that clarifies that for people. I don't think it's a direct causation. It's not something that I can find out tomorrow, but I do believe through data analysis in the next 10 years, we can have that answer. And we're the only population so far that I know of that is like us.
Got it. Okay. Shukran. Aamir bhai, the next, only a few more questions left. Next question is, does vitamin D deficiency increase the risk of breast cancer?
It does. Great. So this is part of my preventative talk. Absolutely, there is great data to suggest that a normal vitamin D level helps reduce the chance of breast cancer coming. And so part of our handouts to our high-risk patients is to ensure that they have a normal vitamin D level. So vitamin D is important not just for bone health, but also for breast cancer.
Got it. Okay. Next question is, what are the common genetic mutations that can be tested for Moomina outside the United States, that is, limited resources? Can you please review the indications besides strong family history?
Yes, essentially it's strong family history. So I can't speak for what India's. I would suggest that because the world is flat essentially, and we all have access. There are places in various subcontinents in the Indian subcontinent that have access to this. India is this very interesting place that is advanced technologically. A lot of our technology comes from this location. So it's just a matter of getting them to the right places. But the biggest indication is family history. I would say just because that person lives or happens to live in India, there's no reason we shouldn't use our current guidelines here. The NCCN guidelines, for example, while they're National Cancer Consensus guidelines, they're not unique, and why not use them for that population, especially for genetic testing? So 2 first-degree family members with breast cancer is one of them. Ovarian cancer, 1 first-degree relative, pancreatic cancer, 1 first-degree relative. This NCCN guidelines are available online to anybody for everybody. So I would use that as who should get genetic testing. That's what we're going to be using to find patients who, through the MLI Cancer Prevention Program, we're going to suggest to get genetic testing. We're going to be using the NCCN guidelines. Now, where do they go is going to be dependent on what part of India they're in. And currently, we're trying to formulate easy avenues, starting with patients in kind of more remote cities. And so hopefully more to come about where they can go in India. But if they live in Bombay, this is available, I believe, at Tata Hospital.
All right. We have 2 more. Is the radiation exposure with 3D mammogram much higher than the standard mammogram?
Say that again.
Is the radiation exposure with 3D mammogram much higher than a standard mammogram?
I don't think it's much higher. I can't remember the numbers off the top of my head. Maybe a radiologist in the group can put this up as a, but I remember and I know that it is not significant enough to cause any concern that even if a woman were to get 3D mammogram, it's definitely higher, there's no question. But even if a woman were to get a lifetime's worth of 3D mammograms, it's not enough radiation to cause them to have, the general side effects of radiation. And I did just want to make one point that whenever I was talking about India, it's generally the Indian subcontinent. So obviously people from Pakistan, Bangladesh, all over that kind of part of the world will be included in that reference. I'm just saying India as a kind of generic example.
Got it. And Aamir bhai, last question. Can the Umur Sehat coordinators approach Saifi Burhani Medical Association America or you directly for opinions?
Yeah, I don't know what's set up with Saifi Burhani Medical or SBMAA. They can absolutely reach out to me directly, and we will be forming local liaisons, inshallah, in the next year. We had a lot of momentum about a couple of years ago with this, and obviously our concepts our time has been consumed by this this pandemic. So inshallah, in the meantime, please don't hesitate anytime. I'm happy to help for anything in this realm.
All right, that's about it. Thank you so much, Aamir bhai Gomberawalla. Aapye apno time apo. It was an excellent presentation. Ghanu janwa malu ane apno teh dil se shukriya ada kariye che from Saifi Burhani Medical Association America and all the Moominin who had joined this webinar. ane akhir mein dua kariye che ke Khuda Taala Ali Qadar Mufaddal Maulani Umar Sharif ne ta roz qiyamat daraz ne daraz kare. Ameen. وآخر دعوانا الحمد لله رب العالمين.
Shukran to everybody that attended.